So a very warm welcome to the ISA online PG classes. And these PG classes are held every Monday evening from 6:30 p.m. As an initiative by the ISA leadership for the benefit of all the postgraduate students in and around the country. And as is customary, we shall begin the proceedings with the Saraswati Vandana. And we invoke the blessings of Mata Saraswati.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा.
So, with the blessings of Ma Saraswati, we'd like to request our Honorary Secretary ISA National, Sukhminderjeet Singh Bajwa sir, to say a few words and initiate the class today.
Thank you, Nishan. A warm welcome to the Dr. Pratibha, Dr. Nagalakshmi and their team of the residents. It's a very difficult case. The surgery is also difficult, the anesthesia is also difficult, and the discussion will also be difficult. But I think whatever the results we will get today after discussion, it will be wonderful. Because this case, they do come as a long case and they do trouble you. And I think by the end of this class, we will be showered with a very good knowledge, wisdom from the residents as well as the teachers. I don't like to waste time here. Before we should start the proceeding, we will discuss the thing later on. Nishan, back to you and Dr. Pratima.
Right, sir. So today we have Dr. Pratima Rathod with us. She's a consultant in Banaras, and I'd request Dr. Pratima to introduce our faculty for the day.
Good evening, respected faculty, dear colleagues and residents. I take great pleasure in welcoming the chairpersons of today's class. First, I would like to welcome Dr. Pratibha Natarajan. Ma'am has done DNB anesthesia and Indian Diploma in Regional Anesthesia. Ma'am is also a member of National Academy of Medical Science. She is currently working as professor and head of anesthesiology at Indira Gandhi Medical College and Research Institute, Puducherry. Ma'am has 14 international and 15 national publications in index journals to her credit. Her areas of interest are regional anesthesia, obstetric anesthesia, and transthoracic echocardiography. Ma'am has been a faculty speaker in various national and international conferences. She has been a faculty coordinator and resource person in ISA and ISCCM state conferences and workshops. Ma'am was also the organizing secretary of ISACON South Zone 2020. She has been the treasurer and joint secretary of ISA Puducherry in the past. She is also a member of National Task Force for COVID and has been the proud recipient of Appreciation Award by Governor of Puducherry for her COVID services. Welcome, ma'am.
Thank you.
Next, I would like to welcome Dr. P. Nagalakshmi, ma'am. Ma'am has done her MD anesthesia from Thanjavur Medical College and is currently working as professor in the Department of Anesthesiology at Sri Venkateshwara Medical College and Research Center, Puducherry. Ma'am has 8 publications in index journals to her credit. She is actively involved in conducting academic activities. She has been ISA secretary in the year 2020 and 21 and treasurer ISACON South in the year 2021. Her academic areas of interest are airway management, pediatric anesthesia, and regional anesthesia. I take great pleasure in welcoming you both, ma'am.
Thank you.
Now I also welcome the speakers for today, Dr. Anuprabha M. and Dr. Lydia N. They are postgraduate residents in anesthesia at Pondicherry Institute of Medical Sciences. They will be presenting a long case on a patient presenting for scoliosis correction.
Yes. Over to you then, Dr. Pratibha ma'am and Dr. Nagalakshmi.
Good evening, one and all. At the outset, I would like to thank our Honorary Secretary, Bajwa sir, and also Dr. Naveen sir for giving us this platform. And a very good evening to Nishan sir and Maruti Pudi ma'am also. So today our PGs will be presenting a long case regarding a patient who's going to come for scoliotic correction surgery. So as you all know, any patient coming to us for a scoliotic correction surgery poses a great challenge, basically because of the complex nature of the patient as well as the complex nature of the surgery. And each and every step of management requires to be addressed meticulously. So today we'll see how our residents have managed a case of a patient who has come for a scoliosis correction surgery. So Dr. Anu and Dr. Lydia, please, you can start your case presentation.
I'll be sharing the screen so that all of you can have a flow of the events.
So by the time you share the screen, Dr. Nagalakshmi and Dr. Pratibha,
Yeah.
this is just to inform everybody that all the audience members will be muted till the time the class is going on. And just in case there are any questions that the audience might have, they can ask in the chat box. We can either take it as we go, so that the flow is not broken, or if anything is left, we can address it by the end of the talk. Okay.
Okay.
So we are starting. Anuprabha, you are going to share your screen or what for the presentation?
Yeah, 1 minute. I'm sharing the screen, sir.
Okay.
Visible, sir?
Is it
Yes.
visible, sir?
Yeah. Make it a slideshow.
Full screen, full screen. Is it fine?
Yeah,
Yes.
fine.
Okay. Sir. Anu, you can present. All the best to you both. Yeah.
Good evening. Today we'll be discussing a case of scoliosis presentation, which is posted for spine surgery. And first we'll look through the patient demographic details. The patient is 18 years old male and he is residing in Viluppuram, Tamil Nadu, and he is from a lower middle class family, and he came with the complaint of progressive deformity of trunk since childhood and difficulty in breathing for 5 years. And coming to the history of presenting illness, the patient had a history of lateral bending of the vertebral column since childhood, and which started at 8 years of age, and it was gradually progressive in nature, and it was associated with the stiffness of the trunk. And there was associated history of difficulty in breathing for 5 years, which was insidious in onset, gradually progressive, and it initially occurred on exertion, but it has now progressed to grade 3 MMRC for the past 4 months, and it has been relieved on taking rest. And there is no associated history of orthopnea, paroxysmal nocturnal dyspnea. And the patient has been complaining of pain over the back for 3 months, which was insidious in onset, gradually progressive, dull aching in nature, non-radiating, and aggravated on activity and relieved on rest. And the patient has also has a history of difficulty in lying in lateral position, but he is comfortable in supine and prone position. And he also has a history of difficulty in walking. But there is no history of numbness of limbs, weakness of limbs, loss of balance, small joint pain, or deformity or foot deformity. There is no history of fever, cough, or sputum production, no history of chest pain, palpitation, syncope, swelling of legs, and there is no history of difficulty in neck movements or difficulty in having food. There is no history of abdominal pain, reduced urine output, urinary or fecal incontinence. The patient has METs of less than 4. Coming to the past history, the patient had no history of congenital deformity or defects. There is no history of similar complaints in the past. He is not a known case of DM, bronchial asthma, TB, or seizure disorder. And there is no history of previous surgeries, blood transfusion, or ICU admission. And there is no history of COVID. Coming to the personal history, the patient consumes mixed diet and he has normal sleep and appetite and regular bowel and bladder habits, and there is no substance abuse. Natal and postnatal history. The patient was delivered at term by normal vaginal delivery. The birth weight was 2.7 kgs, and there is no history of NICU admission. And he was immunized appropriate for age, and milestones development was normal. Family history, there is no history of similar complaints among the family members, and there is no history of congenital anomalies, and there is no history of chronic illness among the family members. And it was a non-consanguineous marriage. And allergic history, there is no history of significant allergies. Treatment history, the patient had a history of analgesic intake, which was on and off for the past 4 months. Coming to the general examination, the patient is conscious, cooperative, and oriented to time, place, and person. Pallor was present, and there is no icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. The patient weighs 40 kgs, and his height is 150 centimeters, and he has a BMI of 17.8 kilogram per meter square. Coming to the vitals, his heart rate is 98 beats per minute, which is regular in rhythm, normal in volume and character, with no radial or radiofemoral delay. All peripheral pulses are felt. BP is 110/70 millimeters of mercury in right upper limb in sitting position. Respiratory rate is 16 per minute, regular abdominothoracic, and saturation is 98% at room air, and temperature is afebrile. Bedside PFTs have been done, which the patient was able to cough, and he had a breath holding time of 17 seconds, and the single breath count was 22. Coming to the head to toe examination, on a head to toe, the head was centered over the pelvis, and there was no obvious craniofacial abnormality, and the right shoulder was lower compared to the left shoulder, and the spine was convex posteriorly and to the left, which indicates left-sided scoliosis, and he had a waddling gait with a normal abdomen and external genitalia, and his extremities were normal with no skin discoloration.
Proceeding to airway examination, his mouth opening is adequate, more than 6 centimeters. He belongs to grade 2 of modified Mallampati class. Dentitions were intact, no loose tooth. Neck movements were adequate. And thyromental distance is more than 6.5 centimeters. Sternomental distance more than 13 centimeters. Mandible protrusion is normal, and TMJ joint was normal. Upper lip bite test of grade 1. Respiratory system examination, his upper respiratory tract was normal. In lower respiratory tract, on inspection, trachea is in midline. Chest wall moves equally on respiration. The anterior chest wall. Right shoulder is comparatively lower than the left shoulder, and right scapula is comparatively lower than the left side. And chest wall moves equally on respiration. There was no supraclavicular hollowing, no crowding of ribs. Respiratory rate was around 18, regular abdominothoracic pattern, and accessory muscles were not used. There was no scar, sinus, dilated veins on the chest wall. On palpation, all inspective findings were confirmed. Trachea is in midline, no warmth and tenderness felt. Vocal fremitus is normally felt on all areas. Chest expansion is 3 centimeter, restricted, and the right side is less compared to the left side. Anteroposterior diameter is of 15 centimeter and transverse diameter of 33 centimeters. On percussion, resonant note is heard in all areas. The supraclavicular, infraclavicular, mammary, axillary, and infraaxillary, and posterior side, suprascapular, interscapular, and infrascapular areas. Auscultation also in all these areas, normal vesicular breath sound is heard, no added sound, and vocal resonance was normal and equal on both sides. Cardiovascular system examination, on inspection, JVP is normal, not elevated, about 6 centimeters of water. Apical impulse is not visible, and there is no obvious precordial bulge, visible pulsation, scars, and sinuses. On palpation, apical impulse is palpable. In left fifth intercostal space, half an inch medial to mid-clavicular line, there is no parasternal heave or thrill. On auscultation, over the mitral, tricuspid, aortic, and pulmonary area, S1, S2 were present, and they are normal, and there is no murmurs. Central nervous system examination, higher mental functions were normal, cranial nerve reflexes were normal, coordination and tone was normal. He has waddling gait and no signs of meningeal irritation. Motor and sensory examination of bilateral upper and lower limb were on normal range. Per abdomen examination, On inspection, it was normal in shape, not distended. All quadrants moves equally with respiration. Umbilicus is normal. All the hernial orifices were free. No visible pulsation or peristalsis. Dilated veins, scars, or sinuses is present. On palpation, no warmth and tenderness felt. Liver is palpable, firm, regular in border, and 1 centimeter below the right subcostal margin. No significant organomegaly. On percussion, resonant note is heard. On auscultation, normal bowel sounds heard, no bruit. Spine examination, head is centered over the pelvis. Vertebra is not perpendicular to the floor. Examination from posterior aspect shows right shoulder lower than the left shoulder and right scapula lower than the left side. Spine is convex posteriorly and deviated to the left side, suggestive of left-sided scoliosis, involving the vertebra from D6 to D12. And on clinical examination, approximate corpse angle is more than 40 degrees. There is no obvious kyphosis, no tuft of hair or swelling, dimple in the midline, no foot asymmetry, no eye-arched foot. So summary of this cases, an 18-year-old male presented with complaints of gradually progressive deformity of the trunk since childhood and progressive difficulty in breathing for the past 4 months. On examination, he has rigid thoracic scoliosis with convexity posteriorly to the left from D6 to D12 vertebra and approximate corpse angle of about 40 degrees with reduced pulmonary reserve.
Okay, Nanu. Since you have come with a diagnosis of scoliosis, now can Lydia, can you tell me the definition of scoliosis, and can you tell me the causes also of scoliosis and what do you suspect in this particular patient?
Scoliosis is actually, it refers to the abnormal lateral curvature of the spine, which is greater than 10 degrees. So scoliosis, most of the time, the etiology will be idiopathic. It will be 70% idiopathic, but in that it will be infantile, juvenile, or adolescent. In infantile, it will be presenting in patients who are less than 3 years. In juvenile, it will be from 4 to 10 years, and in adolescents from 10 to 18 years. Other than this, there will be congenital or acquired causes of scoliosis. From congenital, it can be osteogenic or neuropathic. Osteogenic might be closed with the cause of wedge-shaped vertebra, hemivertebra, fused vertebra, or unilateral bar, or neuropathic causes which will be open, which includes tethered cord, syringomyelia, meningomyelocele, diastetomyelia, or Chiari malformations. And some acquired causes, they include neuromuscular causes, which will be mostly paralytic. Of these, neuropathic and myopathic, or the classification from this side. And neuropathic, it can be either upper motor neuron or lower motor neuron. In upper motor neuron, it might be due to cerebral palsy or spinal cord injury. And in lower motor neurons, it can be due to poliomyelitis, meningomyelocele, or familial dysautonomia. And myopathic causes include muscular dystrophy or myotonic dystrophy. And other acquired causes of scoliosis include mesenchymal disorders, which includes various syndromic disorders like Hurler-Downlow syndrome, and rheumatoid disorders, achondroplasia, or osteogenesis imperfecta. And it can also be due to trauma, which might be either due to a vertebral fracture or surgery. It can be post-thoracoplasty or post-radiation. And other causes might include vertebral tumors, neurofibromatosis, and Morphin syndrome. Here,
where does your patient fit in?
The patient fits under idiopathic scoliosis, which can be adolescent, since he is 17 years old.
Okay. Now, Anu, how are you going to assess the severity of scoliosis?
The severity is assessed by a special technique called the Lippmann-Cobb method, which includes measurement of the corpse angle by the radiographic picture. So here, the curvature of the spine is assessed, and the maximum and the highest and the lowest vertebra is found out. The angle or a perpendicular plane is drawn from the upper border of the highest vertebra, and another perpendicular plane is drawn from the lowest border of the lowest vertebra. and the intersecting angle is known as Cox angle. If the angle is minimum, it won't intersect. So in that case, a perpendicular plane is drawn from the same line, and their intersecting angle is also same as the same angle. So that is Cox angle, and based on this, the severity is assessed.
Now, why do you need to assess the severity?
For the severity, why do we need to assess the severity is we should first, based on the Cox angle, we can quantify the amount of respiratory involvement. So we can, based on the angle, if it is less than 10, it's a normal curvature. But if it is more than 25, it is associated with a increase in pulmonary artery pressure. And if it is more than 40 degrees, we should consider surgical management. And if it is more than 70 degrees, we should suspect a significant decrease in the lung volume in such patients. And if the Cox angle is more than 100, the patient will present the dyspnea on exertion. And if it is more than 120 degrees, it is associated with alveolar hypoventilation, chronic respiratory failure, etc., which will result in right heart failure.
So your patient has a Cox angle of
Cox angle of
40. So that is why you're planning to take up this patient for surgical correction. Okay.
Okay. Now, Anu, will you be able to tell us what are the physiological changes which occur in scoliosis that is of anesthetic concern, which affects our anesthetic management?
Mainly the respiratory system and cardiovascular system is of prime concern. In respiratory system, due to the reduced chest wall compliance, there will be restrictive lung disease, which is of consequences. Then if there is a more severe scoliosis, it may lead to ventilation perfusion mismatch and increase in pulmonary vascular resistance, which may go for pulmonary hypertension. So,
so it is both mechanical and parenchymal lung disease. Mechanical because of the reduced chest wall compliance, and also a parenchymal disease which affects the ventilation perfusion mismatch that we will have to take into consideration. Now, what are the respiratory system changes which occur with scoliosis?
So there is significant reduction in the lung volume and capacities.
Yes.
Mainly the vital capacity is reduced by 60 to 80%. So it causes reduction in total lung capacity. The functional residual capacity also reduces. Expiratory reserve volume reduces. Inspiratory capacity reduces. But the residual volume remains unchanged. So on spirometric analysis, the FEV1, FEC both reduces and their ratio remains normal.
Yes. So here, one important point to notice, chest wall compliance is decreased, and you should know because of the increase in the work of breathing, there is a respiratory rate increase to compensate for the minute ventilation. And ventilation perfusion maldistribution is also very important to note in this case. Okay. So now, will you be able to tell us about the cardiovascular changes which occur as a consequence of scoliosis?
Because of high respiratory rate and low tidal volume breathing, the work of
breathing is increased,
which result in alveolar hypoventilation, and the patient will have hypoxemia and hypercapnia and other secondary electrolyte disturbances. It causes increase in the pulmonary vascular resistance and pulmonary hypertension, will ultimately result in right ventricular hypertrophy and right ventricular failure.
So this will happen if there is a type 2 respiratory failure because of the chronic hypoxia and hypercapnia. Okay. Now, you do a pulmonary function test. What do you expect? What are the abnormalities you expect in a pulmonary function test?
Actually, in scoliosis, the pulmonary function test will follow a restrictive pattern. Mainly, the parameters will be TLC, the total lung capacity will be decreased, and FEV1 and FEC will be decreased, but the ratio will remain normal. So in the flow volume loop, due to the reduction in the total lung capacity and vital capacity, there will be decrease in the size of the curve, and the curve will be slightly shifted to the right. And we can also look for associated obstructive pattern by looking for the post bronchodilator reversibility, which might be present in some of the patients.
Yes, if there is an obstructive pattern associated, then a bronchodilator therapy in the preoperative period will help this patient. So that is why we will have to see for the reversibility with bronchodilator. Okay. Normally, scoliosis shows a isolated restrictive pattern. But if there is an obstructive pattern associated with it, then a bronchodilator in the pre-op period will help in maintaining the ventilation perfusion in the intraoperative period also. So now let's go on to the ABG alterations which we see in the scoliosis.
So the patient
Yes,
will
Anu?
have hypoxemia.
Yeah, louder, please, louder.
This patients will have hypoxemia due to secondary respiratory failure.
Yes.
So the PO2 will be decreased.
Yes.
In case of mild scoliosis, only the PO2 will be reduced. There won't be any PCO2 retention.
Yes.
In case of severe scoliosis, there will be carbon dioxide retention, which causes increase in the PCO2 concentration in the blood and picturized as secondary respiratory acidosis.
Very good. So it's not only in severe scoliosis, but in a long-standing scoliosis, which is progressive, which has a progressive deformity, there will be an increase in the PSCO2, which will lead to the other consequences like pulmonary artery pressure, changes in the pulmonary vasculature also. Okay. Okay.
Okay, now you have done your, you have taken up the history, your physical examination, you have done everything. Now, before preparing this patient for surgery, you need to know the nature of the curve. Why is it so? What are the things? What are the things you will be able to identify with the nature of the curve?
The nature of the curve, it mainly it will have a direct relationship with the respiratory function of the patient.
Yes,
so
exactly.
the degree and severity of the respiratory impairment will depend on the location of the curve, whether it is cervical or thoracic, or age of the onset of the curve, and the speed of onset of the scoliosis, in the degree of curvature or direction of the curvature, and the number of vertebrae involved, and the underlying cause of scoliosis, and if there is any associated comorbidities with the patient, or any pre-existing lung disease. So if the location of the curve, if it is cervical, we can have difficulty in securing the airway.
Yeah, right.
And if the age of onset of scoliosis, that is, if it is less than 8 years of age, it will interfere with the development of the lung. So it will cause lung hypoplasia, and we can have complications related to that. And also, if there is a underlying etiology like syndromic disorders which has been associated with scoliosis, we should rule out any other congenital anomalies which is associated with the syndrome.
Okay. Okay. Good. So I want to know why along with this you always do a pre-operative neurological assessment. Now, why do you do that for patients with scoliosis?
Because this patient with pre-existing neurological deficit have increased the risk of intraoperative spinal cord injury. So that will proceed as a post-operative neurological complications. And also for documentation purpose, to avoid confusion pre and post-operatively, we'll do a pre-op neurological evaluation. And we need to maintain the airway. So while manipulation, we should not injure the cervical region. So our concern is that while tracheal intubation or patient procedure position, we should not cause any neurological damage. And also associated this musculoskeletal abnormalities, these patients has to go through a thorough pre-op evaluation of neurological system. Because with the pattern VP shunt only, we need to take up the patient for surgery. If it is an obstruction, then a post-operative hydrocephalus, which is a life-threatening complication, can occur. And also interaction of the muscular dystrophy patient with malignant hyperthermia. So we need to avoid drugs like succinylcholine and the halothane to prevent the malignant hyperthermia, and also other succinylcholine related cardiac dysrhythmia complications.
Okay, good. Now, what are the preoperative investigations you would like to do? You need to justify why you're doing these investigations. You need to justify.
Our patient is a young patient. He's a 17 years old male. So complete blood count would be enough for him because scoliosis surgery is a spine surgery and it involves huge blood loss. So we should note the preoperative hemoglobin, and we should correct anemia if present. And also we should do a blood grouping and cross matching to reserve blood. And even we can, if there is anemia, we can even arrange blood in the OT before the start of the surgery itself. And if the patient has any symptoms which is involving respiratory functions, that is, for example, this patient, he has dyspnea on exertion, and so we can do a PFT, which we can rule out. We can rule out the diminished pulmonary reserve, and we can do a pre-op ABG to find whether if there is any hypoxemia which is associated with significant reduction in vital capacity, and ECG echo are done to rule out pulmonary hypertension in these patients and right heart failure, which is due to the alveolar hypoventilation, which is associated with scoliosis. And for a normal patient, we can do a complete blood count, blood grouping, cross matching, urea create, serum electrolytes, which are baseline, along with the chest X-ray, spirometry, and ABG, with post bronchodilator assessment for the presence of obstructive component, and ECG echo. In patients who have airway difficulties, we can do a cervical spine X-ray lateral view for to look for adequate neck extension and flexion, and any narrowing in the airway, or any presence of scoliosis in the cervical region.
Okay. Now, how are you going to optimize your patient? How are you going to prepare this patient?
So pre-operatively, a thorough and detailed history has to be noted, both the present and past medical illness. Then assessment of cardiopulmonary reserve has to be done. Yes. By history, we can note for the dyspnea on exertion, and we can ask for the effort tolerance, and rule out the lung parenchyma issue. Then a thorough head-to-toe examination to rule out other congenital lesions if it's there. Spine examination and airway examination in case of cervical scoliosis or Marfan syndrome, which has high arched palate. And systemic examination to rule out pulmonary hypertension. We can clinically determine the parasternal heave for right ventricular hypertrophy, or loud P2 in pulmonary area, or symptoms of signs of right ventricular failure like rise JVP, tender hepatomegaly, or pedal edema. This has to be thoroughly evaluated in the preoperative period itself. Then we need to optimize the patient before proceeding for surgery. Since it's not an emergency procedure, so we can thoroughly optimize and proceed for elective surgery. So we need to encourage the patient on coughing, because as their inspiratory muscles are weak, so we need to train them.
Teach the patient about coughing and incentive spirometry. Yeah.
Then optimize the nutritional status. Anemia has to be corrected pre-operatively. And in bronchodilator therapy, if needed, can be given. And adequate volume status has to be mentioned. And intraoperative wake-up test is a procedure for neurological monitoring. If it is that has to be done, we need to counsel the patient pre-operatively about the entire procedure. Like in between the procedure, in between the operation, you will be open up and asked to squeeze the hand or move the finger, but you won't feel any pain or discomfort, and you won't have any recall of the period post-operatively. And we need to notify the blood bank and intensive care unit regarding the major blood loss and post-operative mechanical ventilation and ventilated backup. If needed, we can do for pre-op autologous transfusion if the patient hemoglobin status is adequate, or correction of anemia has to be done pre-operatively.
Our patient, what about our patient? Will he qualify for pre-operative autologous transfusion, or?
Clinically, he has pallor. In a blood investigation, if it's anemic, he will optimize the anemic status.
Very good, very good. Okay.
Now, since you have optimized the patient, you are ideally supposed to talk to your surgeon also what is your plan of anesthesia and what is the surgical procedure he is going to do. Will the surgical procedure actually influence your anesthetic management?
Yes, ma'am. Actually, only main thing is blood loss. So usually we'll do a posterior approach, and this procedure is associated with the considerable blood loss, which will depend on the procedure, the operative time, the number of segments used, and whether deliberate hypotension is used. As we say, even if we are using deliberate hypotension also, it is is also associated with the high blood loss. That is, it can range up to 15 to 25 ml per kg, and this will measure up to 1 to 2 liters in a 70 kg patient. That is, it's a huge amount. So we should look for this blood loss, and we can also have post-operative bleeding in these patients after spine surgery. So we'll need monitoring of these patients in the post-operative period also, and also the patient will have other muscle dystrophies like Duchenne's or cerebral palsies, and they will have diminished reserves. So that should also be taken care of. And the patient, before taking the patient to the operating room, we should make sure that the blood is available, and all the blood bank should be notified, and the blood product should be made available. And another
Another important thing is
another
positioning.
important thing is positioning. Positioning is for a posterior approach, we'll have a prone position, and which has its physiological effects, and we should take care of that. And also for anterior approach, we can put in either supine or in lateral position. And along with this, there can be a significant third space losses also. So these should be replaced, and these are replaced with a balanced salt solution of 5 to 7 ml per kg per hour. And the anesthetic technique and surgical approach, the surgical approach and technique, it should also be discussed with the surgeon.
Oh,
So if it is an anterior approach, we might require a DLT also. That is why we should know the surgical plan, and we have to talk to the surgeon. So
they may go in for one lung ventilation. Anterior approach, they may go in for one lung ventilation. Okay. So now you have optimized your patients, you have spoken with the blood bank, you have spoken with your surgeon. So how are you planning to conduct the anesthesia?
So my plan of anesthesia for this patient will be general anesthesia with endotracheal intubation with controlled mechanical ventilation. So I'll start the patient with adequate pre-optimization and pre-medications, and after connecting to the standard ASM monitors, along with the intraoperative monitoring, which will follow this time. And
we'll discuss. Now you go about the induction.
So first I'll pre-oxygenate the patient, followed with induction. We can do a intravenous induction with propofol or thiopentone, and we can use a neuromuscular blocker, NDMR, and we should avoid succinylcholine in case of neuromuscular disorders. And we can do as it is a prone position, and putting a normal tube might go into kinking or any other complications. We can actually opt for a flexometallic tube for orotracheal intubation. And in cases of cervical scoliosis with difficult intubation, anticipated difficult intubation, we can do a awake fiber optic intubation also. And if it is an anterior approach, as said earlier, we can opt for a double lumen tube, and if it is a posterior approach, we will go for a regular single lumen tube. And the main concern is that we should provide an anesthesia which is suitable for spinal cord monitoring while providing analgesia and amnesia. Maintenance will be we'll do a combination of low dose potent agent, that is inhalational agents. We'll keep the MAC less than 0.5, and we'll compensate it with intravenous agents, and we can maintain with 50% oxygen per hour mixture, along with the low dose dexmed infusion and primarily opioid based intravenous anesthesia. And along with that, non-depolarizing muscle relaxants are used, and intravenous fluid should be warmed, and a warming mattress device should be preferable. And here the main concern is the conduct of hypotensive anesthesia, that is, will maintain the MAP of 65 to 75 millimeters of mercury. Even then, it is associated associated with certain complications. That is, if the MAP is very less, it will interfere with the perfusion of the spinal cord. So it might lead to spinal cord ischemia also. So we should maintain the MAP
Spinal
with
perfusion pressure.
65 to 75 millimeters of mercury while avoiding the hypoperfusion.
Why do you have to use hypotensive anesthesia?
Mainly to decrease bleeding.
Bleeding, yes. Bleeding is an important concern. So we'll have to use hypotensive anesthesia, maintaining a MAP of 65 to 75 to prevent the spinal perfusion pressure to fall down to less than 60, so that we do not cause an ischemia of the spine. Okay, so that is also an important concern. Now, what are the intraoperative monitoring techniques we use in scoliosis surgery?
So we'll use the AAC standard monitors first.
Yes. What are the AAC standard monitors, Hanu?
The 3-lead ECG, non-invasive blood pressure, pulse
Yes.
oximetry, and capnography.
Okay.
Apart from
Other
that,
important monitors?
we can go use invasive blood pressure also. Since there
Okay.
is anticipated blood loss and prolonged
loss.
surgery, we want to see minute-to-minute blood pressure. In that case, invasive blood pressure can be used, and temperature monitoring by core body temperature. Urine output we need to monitor hourly, and
Yes.
air pressures and also tube placement has to be checked then and there.
Then and there.
In prone position surgery, there may be chance of tube dislodgement. And apart from that, we'll secure a central line. So in that, we can see a CVP monitoring and give fluid management accordingly. Neuromuscular monitoring with TOF has to be seen. And specific neurological monitoring for spine surgery is that evoked potentials. The
Yes.
somatosensory evoked potential and motor evoked potential has to be monitored. This is of specific indication in high-risk patients.
Yes.
And
Intraoperative neuromuscular monitoring, IONM. Okay.
And if there is TIVA, we use a depth of anesthesia
Anesthesia
monitoring by
monitoring.
bicentennial index.
Okay. Very good. So all these things are important. Now, to minimize the neurological complications, what are the important monitoring techniques applied specifically in scoliosis surgery?
Mainly for evoked potentials, it's only somatosensory evoked potential, that is SEEP, and motor evoked potential and MEEP. And also that we can use wake up test, which has now been replaced by MEEP.
Potentials.
And why we are doing this intraoperative neuromuscular monitoring is that we should look for spinal cord injury, which might be due to any distraction of the cord or straightening of the deformity, which will compress the spinal cord and disrupt the arterial blood supply to the cord, or if there is a reduction in the spinal cord perfusion pressure, or if the spinal cord and nerve roots are injured directly, which are injured directly, which is mainly by the instrumentation by the surgeon. And here the critical zone will be from T4 to T9, and some certain high risk groups which will definitely need this intraoperative neuromuscular.
So here we should take a concern. There are two ways of damaging the spinal cord. One is direct injury to the spinal cord and the nerves because of the instrumentation, that the Harrington rod placement. So because of that, there might be a direct injury to the spinal cord, or because of the decrease in the fall in the spinal perfusion pressure, as we mentioned already, there might be an ischemia in the spinal cord. So to rule out both of these things, we will have to use an intraoperative neuromuscular monitoring. Now, what are the high risk groups who will require a intraoperative neuromuscular monitoring?
The high-risk groups include the patients with severe rigid scoliosis, that is a corpse angle of greater than 120 degrees, and patients with associated kyphosis, or patients of neurofibromatosis or congenital or post-infectious scoliosis, along with patients who have a pre-existing neurological deficit, and in cases where more invasive instrumentation is required, or if the congenital scoliosis is associated with intraspinal anomalies like lipomas, any tethered cords, or any cysts or teratomas. These patients will be needing IONM.
Okay, now let's talk about the somatosensory evoked potential. What is SSEP and how reliable is it to predict the spinal cord injury? Why are we using it? Anu, will you be able to tell? Yeah.
SSP is the somatosensory evoked potential. It assesses functional integrity of the sensory pathway. That is the posterior column pathway. It will start from the peripheral nerve, proceed along the posterior column of the spinal cord to the subcortical region that will be the cortex. So the entire integrity is assessed by these potentials. So based on the latency and amplitude, those are the two parameters. It will assess integrity of the spinal cord. Latency is the time interval between the electrical stimulus of the peripheral nerve and the response of the evoked potential. So that time interval is known as latency. And amplitude is that the recorded response voltage or the height of the response is known as the amplitude.
Yes, very good. So how do you do that?
For this has to be seen and monitored intraoperatively. A baseline thing has to be recorded, which is used as a comparison. So a reproducible and reliable baseline evoked potential has to be done before induction of anesthesia. So in that case, after anesthesia, if for checking.
So what are the probable changes which can occur in the intraoperative period if there is a problem or injury to the spinal nerves or because of the fall in the perfusion? What can happen?
There may be increase in the latency period.
Yes.
Significance is 10 to 15% increase, or there may be decrease in the amplitude. 50% decrease. So if there is occurrence
or there can be a complete loss of the evoked potential also from the baseline. There can be a complete loss of evoked potential also. Okay. Proceed.
And if there is increase in latency or decrease in the amplitude, we need to have a suspicion of spinal cord injury.
Very good. Now let's talk about MEP. So these are the probable causes of SSEP. And now what is motor evoked potential?
Motor evoked potential is generated mainly by the application of transcranial train of electric stimuli, and these responses will be recorded from the spinal column, along the spinal column, or in the peripheral nerve, or in the innervated muscle itself.
So this mainly tests the integrity of the anterior column. Okay, SSEP tests the integrity of the posterior and the lateral, and MEP tests the anterior column. Okay, now what should be done if the SSEP or MEP signals become abnormal? That is, if there is an increased latency, or if there is a decrease in the amplitude, or if there is a loss of evoked potential, what are we supposed to do?
So first we need to ensure that the spinal cord perfusion pressure is adequate. So we need to correct the hypovolemia and the anemia status in the period. And we need to increase the oxygen delivery. So arterial oxygen tension has to be optimized. And if there is increase in the PCO2 level, we need to be normalized that. Then if there is any surgical causes for the spinal cord injury, so we need to ask the surgeon to loosen the instrumentation and check for any probable tangling. And if it is not corrected by these measures, then we can proceed for the other method of checking, that is wake-up test, that will confirm the if there is a presence of spinal cord injury or not.
And one important thing you have to note here is we should check if there any of our anesthetic drugs is causing a increase in the latency or fall, because our you will know that what are the significant effects our anesthetic agents will cause. Now, madam will take over.
So now, Lydia, Anu has told that she'll be doing the wake-up test if there are any abnormalities seen in the SSEP and MEP. So this is the only one indication right now nowadays to do the wake-up test. Okay. So can you just tell me how do you do the wake-up test? One of you.
Yes, ma'am. Wake-up test was first identified by Stagnera. That was called as Stagnera's wake-up test.
Wake-up test, exactly.
This will assess the integrity of the motor pathway. So we need to lighten the depth of the anesthesia plane, then ask the patient to follow certain commands. So first we need to wake up the patient and ask them to squeeze the hand, squeeze our hand, so that we need to know whether he is responsive or not. Then we need to order some commands like move the toe or move the feet. If it's able to do, then the spinal cord integrity is good. If If it's not able to do, then we need to have a suspicion of damage. Once he is able to perform the test, we quickly deepen the plane of anesthesia with either propofol increment models or increase the dose of the inhalation anesthetic agent. And also we'll give a benzodiazepine to avoid the awareness post-operatively.
So you told you're going to deepen your patient once your patient is moving here. But when you try to wake up the patient, basically you have to come down, you have to lighten the plane of anesthesia. So when you're answering, you're supposed to tell, you have to lighten your plane of anesthesia, and then you'll see whether your patient responds to your commands. Now, since we have come to this now, can you tell me the how your anesthetic drugs will influence your wake-up test? Your neuro monitoring, not wake-up test, your neuro monitoring.
Yes.
Ma'am, there are two questions on SSEP and motor evoked potentials. Can we take the questions with your permission?
Yes, ma'am.
The question is by Dr. Muthu Kumar. His question is, propofol also causes interference with SSEP and MEP. What dose is recommended for the infusion and what alternatives are available? And he has also asked, can ketamine be used for the same?
So
This question will be answered as we go through the anesthetic drugs which are causing.
that was the next question to the students, basically.
Can we take this question later? Let them finish.
Yes, ma'am.
Yeah.
Because it's going to follow the answer.
It's following.
It's following.
Yeah, it's following. Yeah.
Actually, we'll discuss about the anesthetic effect of anesthetic agents on sleep and NEEP. First, benzodiazepines, they'll increase the latency and decrease the amplitude of sleep. And propofol will increase the latency and has no effect on the amplitude, whereas thiopentone will increase the sleep, but it will decrease or has no effect on the amplitude. And etomidate will increase both the latency and amplitude, and ketamine will increase both the latency and amplitude of the sleep. And fentanyl has absolutely no effect on sleep and NEEP. And nitrous oxide will have no effect on the latency, but it will decrease the amplitude. Isoflurane and sevoflurane, that is the inhalational agents, mainly they'll increase the latency and decrease the amplitude. And muscle relaxants also will have no effect on either sleep or NEEP. And the physiological changes.
So 1 minute, Lydia. I'll just answer the question which Dr. Pratima had raised. Dr. Pratima, is it audible?
Dr. Muthu had actually asked this question.
Dr. Muthu Kumar had asked this. So, see, of all these drugs, only propofol has it has no effect on the amplitude. Amplitude is the one which we are mostly concerned. More than the latency, in IONM monitoring, amplitude is what we are concerned. Now, propofol, if it's used as an infusion in the intraoperative period for inducing hypotension, then it can be titrated and it can be used in the dose of 0.5 to 10 mg per kg per hour. So now the better alternatives are available, which are Dexmed, which has a least effect on both SSEP and MEP, and which can be used in the dose of 0.2 to 0.7 micrograms per kg per hour. So dexmedetomidine has no effect on the of all the anesthetic agents, it has the least effect on the SSEP and MEP. And if you note, fentanyl and other opioids, they have the least effect on both the amplitude and latency in the evoked potentials. So a combination of opioids and dexmedetomidine as an total intravenous anesthesia will be a better choice for patients who are planned for IONM, intraoperative neuromuscular monitoring. Does this answer the question, Dr. Pratima?
Yes, ma'am.
Yeah,
yes,
fine.
I guess so. Dr. Ingrani ma'am also believes that remifentanil is getting launched and it will be a game changer.
I didn't take that because it is not regularly used in our setup, no sir. So that's why I didn't comment on remifentanil. Now, when it is used, then we will have the option of remifentanil also. Yeah. Okay.
And Dr. Bhuvna had a question. Is this SSEP and MEP monitoring done in all the institutions?
Actually, to say the truth, it is being done only in specialized setups. Even in our hospital, we are not doing. So basically, in setups where SSCP and MEPs are not available, wake-up test is the only choice. And again, wake-up test has its own complications. Like, the patient wakes up startled, that can result in problems with the instrumentation. Your tube may get dislodged. There are a lot of other issues. Complication associated wake-up test.
Post-operative awareness is another complication of wake-up test. That is why we will have to counsel and prepare the patient in the pre-operative period itself. And a TIVA will be a better option, and along with a low-dose inhalation agent. And immediately after the wake-up test, we are supposed to use a benzodiazepine because it causes antegrade amnesia also. Benzodiazepine has the property of antegrade amnesia also. That is why we use benzodiazepines in the immediate period after the wake-up test. This is one point. And IONM, about IONM, it is it is ideal to do in all scoliosis surgery. Now, to make it, to introduce it, there are a lot of freelance people who are using intraoperative neuromuscular monitoring devices where they bring it to the institution if we order. It is ideal to use, and also from the medical legal point of view, it is better to use an IONM. That is the concern. Okay. Is there anything else, or can we proceed?
I think we can proceed. Yeah, we can proceed. We'll check up the other set of later on. Yeah.
Yeah.
And Anu, you're doing very well. Anu and colleague, just a little louder, please. Okay.
Yeah. Now, where did we stop?
Now, complications.
Complications, wake-up test, and now.
So now we have seen the intraoperative neuromonitoring. I would like to know what are the techniques you will be using to minimize transfusion requirement also.
Actually, ma'am, this as mentioned earlier, scoliosis surgery is a surgery which is involving a huge amount of blood loss. So we have to do certain blood conservation strategies that will reduce the blood loss, and we should start from the preoperative period itself. So the preoperatively we'll optimize as our patient also has a pallor, we'll look for the hemoglobin, we'll optimize the blood HB preoperatively with
what is the target HB which you would like to achieve?
11
around 10 to 11 will be ideal. Okay.
And preoperatively we'll start, we'll optimize with oral or intravenous iron therapy or blood transfusions preoperatively if it is so severe, but intraoperatively we can use certain blood conservation strategies which will reduce the blood loss, as well as we can compensate for the blood loss which has already occurred. So mainly we should minimize the intra-abdominal pressure. So because the intra-abdominal pressure, when it increases, it will be transmitted to the veins. And the veins, if the epidural venous plexus, it gets, if the pressure is increased, there will be more bleeding, obviously. So we should minimize the intra-abdominal pressure, and this can be done by careful positioning of the abdomen, by avoiding external pressure of the abdomen, and we can use muscle relaxants and plane of anesthesia also we can tighter based on that. And one of the techniques is isovolemic hemodilution. That is, before incision, the hematocrit will be lowered 20 to 25% by removing blood aseptically and storing it in anticoagulated bags. And after that, this volume is replaced when there is a intraoperative blood loss. And intraoperatively, the previously collected blood, which was collected preoperatively, it will be used for transfusion.
This is autologous blood transfusion.
Yes, ma'am, autologous blood transfusion. Because certain communities like Jehovah's Witness, they'll prefer autologous blood
Blood
transfusion.
transfusion. Very
So
good.
we can use such techniques in them also. And these patients will require a central venous catheter to perform this technique. And along with that, we can do a salvaging of blood. So that is, we'll use cell salvage technique, where the 50 to 60% of the red blood cells which are lost will be recovered, concentrated, washed, and returned to the patient with commercially available auto transfusion devices.
Yes.
And these blood which are salvaged, they'll lack of platelets and plasma, but RBCs will be adequate. That is, it will have a PG of 50 to 60%. And we can use antifibrinolytic drugs like epsilon aminocaproic acid and tranexamic acid, which can decrease the blood loss in patients. And we can use already mentioned the deliberate controlled hypotension, which will decrease the blood loss and also improve the operative conditions during the spine fusion surgery. And the disadvantage of deliberate hypotension is that there is a potential of decrease in the spinal cord flow, which is compromised with resultant spinal cord injury.
Very good.
One thing I would like to mention here is like I always prefer, or most of the centers usually prefer aminocaproic acid, because this tranexamic acid has a seizurogenic potential. So in patients with already having this muscular dystrophy who have a higher incidence of seizurogenic potential, it's always better to go in for a aminocaproic acid. And one more thing you should remember is always you have to give a loading dose followed by infusion dose of these drugs. Before your fibrinolytic pathway gets activated, it is always better to start off these drugs. Okay.
Because these are antifibrinolytics, right? So before the fibrinolysis is started, then we will have to load the patients with these drugs. Okay. So now 4 hours into the surgery, the surgeon reports some bubbling in the thoracic portion of the wound. The ETCO2 drops suddenly from 35 to 18. BP falls, there is tachycardia, and saturation falls down to 90, then 85. And now, what is your working diagnosis and how will you proceed? Anu?
From this scenario, there is a positive finding of bubbling in the thoracic portion of
Yes.
wound.
Yes.
And there is a drastic reduction in ETCO2.
ETCO2.
And a sudden drop of saturation.
Yes.
Fall in blood pressure and a rise in heart rate. So
louder, Anu, please.
There is fall in blood pressure and there is an increase in heart rate. So
yes, this is the scenario. Now, what is your working diagnosis?
This points towards in this surgery, it may be a cause of venous air embolism.
Yes, very good. So this points to venous air embolism because the epidural venous sinuses, they are capacitance vessels and they are open and they don't have a musculature to close. So that is the important point which we will have to note in a scoliosis surgery. And for this purposes, if needed, what additional monitoring can you do if available in your institution? Can you use some special monitor where you can detect this venous air embolism, expecting the worst? Can you use transesophageal echocardiography?
Yes, ma'am. It can detect the embolism.
Yeah, transesophageal echocardiography. If you are anticipating scoliosis, venous air embolism in scoliosis surgery, TE can be used. Now, what other intraoperative complications will you think of?
Other intraoperative complications, mainly blood loss or any spinal cord injury or complications associated with prone positioning, like vision loss and venous air embolism and pneumothorax if it is a correction of thoracic scoliosis.
Yes, pneumothorax is another important complication. How will you identify pneumothorax in the intraoperative period?
There will be raise in the airway pressures.
Yeah, that is why we will have to note for the airway pressures in the baseline. So this is why initially when you told about monitoring, you told about airway pressures, right? So there might be a drastic rise in the airway pressures and the bag will become very tight. It's a tight bag syndrome. So it will be non-compliant also. Okay. Now let's get back to the venous air embolism. What are the signs? When do you suspect venous air embolism?
So the drastic fall in ETCO2 and drastic reduction in the saturation, tachycardia and hypotension.
Okay.
And also in the wound site itself, there will be bubbling sound. And if you
Yes.
oscillate it through the esophageal stethoscope, there will be a gurgling murmur can be heard.
Yes. If you use a TEE, then you will note for the venous air bubbles in the atrium also. Now, how will you manage the venous air bubbles? Louder or no louder?
So we need to wash the wound area with saline irrigation
You
first.
need to flush the surgical, flood the surgical field.
Area
Yes.
with saline irrigation.
Yes, very
Also,
good.
this will minimize the air entrainment through the epidural venous.
Yes, very good.
And also we need to increase the O2 concentration to 100% oxygen and cut off the nitrous oxide.
Yes.
And we need to increase the intravascular volume load to increase the central venous pressure. So the air that is trapped will come to the right atrium and it can be easily removed.
Now that you have a CVP, if you have a CVP, what procedure can be done?
We need to alter the position of the patient. We need to turn the patient to left lateral decubitus position and into 30-degree straddle and buck head down should be given.
Why do you do this? Now you have a CVP in situ. What else can be done?
So we can aspirate the air bubble.
Very good. So if you have a TEE and a CVP, then you can aspirate the air under guidance. So this is one important thing you can do. Very good. That position is also called as Durant's position, as you have mentioned. Now, we were speaking about the prone positioning in the posterior surgeries. Most of the scoliosis surgeries are done in the posterior, prone position, posterior approach. What are the complications and what are the physiological changes associated with prone positioning? One of you can enumerate. Yeah.
So the physiological changes associated with prone positioning in the central cardiovascular system, there will be increase in the intrathoracic pressure, decrease in the venous return, decrease in the stroke volume. There will be minimal changes in the heart rate and there will be decrease in the cardiac output, but the mean arterial pressure is maintained. And due to the compression of abdomen, there might be IVC obstruction, which will in turn lead to engorgement of epidural spinal vessels.
Normally, will abdominal compression occur?
No.
We must take care that we don't compress the abdomen and the abdomen is free. Otherwise, there will be engorgement of the epidural veins. Okay, and it will lead to a
excessive
blood loss,
as mentioned earlier.
Okay. Okay. Now, what are the respiratory system changes?
In the respiratory system changes, there will be increase in the FRC and PaO2. And in obese patients, lung volumes, compliance and oxygenation will be better than supine position. And there will be uniform distribution of pulmonary blood flow and the VQ, that is ventilation perfusion matching, will be improved.
Yes,
and the complications and precautions which has been associated with prone positioning, mainly in the face and eyes, we should check whether the eyes are properly taped, and we should make sure that there is no pressure on the eyes, ears or nose, and we should check the tongue in the tongue if it is in the mouth and it is not protruding between the teeth. What are the possible complications which we can expect from this is, we can expect corneal edema or postoperative visual loss along with skin or facial necrosis and reduced and lymphatic and venous drainage, which can lead to macroglossia. Coming to the airway or neck, we'll maintain 1 to 2 breaths, finger breaths between chin and the chest, and we'll avoid excessive neck flexion or extension. And we should check that if there is, if there should not be any extrinsic pressure on the anterior neck. And the complications we'll expect in this is any face, airway or tongue edema, or extrinsic airway compression or endobronchial intubation, or carotid or vertebral artery dissection and cervical cord injury. In case of arms, we should pad all the bony prominences, and the shoulders and elbows should be abducted less than 90 degrees, and the height of arm board is at or below the level of the table, and we should avoid excessive traction on the shoulders or pronation of forearms if the arms are tucked. And the possible complication is that we can expect injuries of brachial plexus, ulnar or radial nerve injuries. That's why we are doing the padding of all the bony prominences. And in legs also, we'll do the same thing. We'll pad the bony prominences. We'll avoid stretching of femoral, sciatic and lateral cutaneous nerve. And we'll elevate the knees a little to decrease tension on the back. And we'll elevate the ankles so the toes are hanging freely. And the possible complications here will be the nerve injuries, that is femoral, sciatic, or lateral cutaneous or lateral peroneal nerve injuries, and skin and limb ischemia. In the chest, we should check whether the chest is well padded, and we'll check the position of the breast in case of females. And if using bolsters, breast should be positioned medial to the bolster. And the complications will be reduced chest wall complaints, high airway pressures, which will lead to barotrauma or pneumothorax, and skin and breast necrosis. And in abdomen and pelvis, we should check whether the abdomen is not overly compressed, and we should check that there is no pressure on the male genitalia, and we should check the urinary catheter if it is not kinked. And the complications we'll expect here is any visceral ischemia or compression of IVC, and high intra-abdominal pressures, which will lead to increased venous pressure, which will result in greater blood loss in the surgical field.
Yes, very good. So I would like to reiterate 3 important points. One is padding of the pressure areas. Number 2, since this is a prone position and we are using a flexometallic test, flexometallic tube, during the wake-up test, the patient, there is a possibility that the patient bites the flexometallic tube. So we will have to use a soft bite guard to prevent the patient from biting the flexometallic tube. And number 3 is you will have to keep the arms, since this is a prone position, you should keep the arms in a physiological position. You should not hyperextend, so that it is unphysiological and it will lead to traction of the brachial plexus. These 3 are very important things to note in the prone positioning and in scoliosis surgery also. Okay. Okay.
So now, what's your plan? What are you planning? How are you going to extubate this patient?
For this patient, he has reduced pulmonary reserve, so we'll plan for post-op elective mechanical ventilation and extubate once the criteria is met. So we need to wait for the patient once he is awake, obeying commands, and we need to take an ABG if it's a normal range, then check for the vital capacity. If it's greater than 10 ml per kg, and tidal volume generating of about 3 to 6 ml per kg, and respiratory rate should be less than 30 per minute, and inspiratory force should be greater than 30 centimeters of water. If these criteria are met and the ABG is normal, we can proceed for extubation of patient.
Very good.
So now you have extubated your patient. How are you going to protect his, how are you going to optimize his post-operative pulmonary status? What are the things you're going to do?
Actually, ma'am, post-operative pulmonary optimization is very important because the patient will have a decreased pulmonary reserve. So we are already asking the patient to do incentive spirometry pre-operatively, and we teach him about the coughing and deep breathing exercises. We'll do the same post-operative also. So we'll do incentive spirometry post-operatively, and we'll ask the patient to cough and take deep breaths. And we can also use bronchodilators along with adequate pain management to reduce post-operative pulmonary complications.
Yeah, you need to be very cautious with the use of opioids also. Okay. And what are the other complications you can expect the post-operative period?
There may be chance of development of pneumothorax, and atelectasis of the lower lobe of lungs can lead to pleural effusion or hemothorax. If there is any thoracic duct injury intraoperatively, patient may go for chylothorax also. This neurological injury has to be monitored post-operatively also. And if there is prolonged period of fasting, there may be chances of adynamic ileus. So we need to start the NG feeds as early as possible.
Very good.
And there is a chance of post-operative nausea vomiting also.
Okay. Okay.
So now you have enumerated all these post-operative complications, right? So expecting all these complications, any laboratory test has to be ordered in the post-operative ward to
Yes. So the lab test in the post-operative ward, because we are doing elective mechanical ventilation and extubation, we'll do an ABG. And once the ABG is good, we'll extubate the patient. And as this surgery involves a lot of blood loss, we'll do a post-op HB and HCT, and we can optimize the HB post-operatively also. And serum electrolytes are done because when there is an incidence of syndrome of inappropriate ADH secretions in patients undergoing
ADH
scoliosis
also,
surgery
yes.
post-operatively. So this will result in hyponatremia. So we'll check for the serum electrolytes to rule out this complication. And along with that, if there is any introp AKI due to decreased perfusion, we can do the blood urea nitrogen and serum creatinine. And if the blood loss if it has been significant, we look for any coagulopathies by looking at the platelet count, prothrombin time, and APTT. So which will where we look for coagulopathies in
Okay.
such
So
patients.
now you're expecting so much electrolyte imbalances. So what is the ideal fluid which you use in the post-operative period?
So first of all, we need to avoid hypotonic fluids in
Yes.
the 24 to 36 hours. So for
Yes.
that, we can replace with isotonic fluid, preferably
Yes.
wriggle lactate solution,
Yes.
to
Very
maintain
good.
the urine output of 0.5 to 1 ml per kg per hour.
So you
So-
must ensure the target organ perfusion. So target organ perfusion is usually seen by the urine output. So that is why we have to monitor intraoperatively also. Urine output has to be monitored every hour in the intraoperative period also. Okay, then
this has to be continued and supplemented till the oral feeds are properly taken by the patients.
okay, very good. So now you told about the pain control in the post-operative period because pain will cause a restriction and decrease in the chest wall compliance also. The patient, it will prevent the patient from coughing or doing deep breathing exercises or in-center spirometry. How do you take care of the pain in the post-operative ward?
The pain management in the post-operative period, mainly it will be multimodal. Actually,
Yes.
we'll use multiple drugs which will counteract the pain so that the patient is relieved of it. We'll use starting with the basic acetaminophen, paracetamol, NSAIDs we can use. We can use gabapentin, ketamine, opioids, or lignocaine.
Yes.
Lignocaine infusion can also be done, can be given for the patient.
Yes.
And we can use patient controlled analgesia so that the patient alters the analgesic dosage according to his requirements. And buprenorphine patch is used for cases where we need a prolonged pain control, and we'll need a monitor
Basal analgesia.
basal
See,
analgesia.
if you can use a buprenorphine patch or a fentanyl patch also for a basal analgesia. It takes care of the pain for a period of 7 to 10 days. So on top of it, if the patient complains of pain, then you can add on with the NSAIDs, paracetamol, or any other method. And intravenous patient controlled analgesia with short acting drugs like remifentanil or dexmedetomidine can also be used in the post-operative period, provided you can give a lockout period. A baseline infusion, you have to set 3 parameters. So one is the basal infusion, and number 2 is the bolus, and then the lockout interval, so that the patient does not use a excessive dosage of these drugs, because dexmedetomidine causes sedation and also bradycardia. Fentanyl causes respiratory depression also. So when you're using patient control analgesia with opioid, we have to take care of all these things. So there is a chance that the patient goes into respiratory depression that has to be monitored in the post-operative ward. So a multimodal analgesia can be used. Is there any other method? Any other method which the surgeon can do for a post-operative pain management? Can you advise the surgeon to do?
Epidural analgesia he can give by himself. Epidural catheter placement or epidural.
No, epidural catheter, it is not epidural catheter placement, but intrathecal morphine can be used, injected by the surgeon in the intraoperative period, can be done under vision. Right? They are opening up the spinal cord, they can do it, and care must be taken not to inject local anesthetic, but morphine. If you are using that technique, then you should take care of the post-operative respiratory monitoring, because morphine causes delayed respiratory depression. Okay, after 4 hours, 5 hours, but it will take care of the pain also, but you will have to be concerned about the respiratory depression also. Very good. This is the post-operative pain management. What other thing will you think of? No, the answer is here.
How are you going to manage
Management.
PONV?
We can start on prophylactic therapy also based on our alpha score. There are risk factors in that: female, gender, non-smoker, and past history of PONV and post-operative opioid use. This
Okay.
patient, we are using post-operative opioids, so he is also considered as risk for PONV. So
Yes.
even there is no risk score also, we need to supplement with either one group of antiemetic drug. Preferably, we'll start with the 5H3 antagonist ondansetron. If
Yes.
there is increase in number of risk factor, we can supplement with dexamethasone
Dexamethasone.
infusions,
We'll be using dexamethasone in the intraoperative period also because of the prone positioning to reduce the airway irritability and spinal cord irritability also. We do use the steroids. So we can use it for the post-operative nausea, vomiting also. Okay, very good. Now we have come to the end of the discussion. I think it was fruitful. And
Dr. Nagalakshmi, can you summarize whatever our PG has?
yes. I'll summarize. Scoliosis is the most common idiopathic, most commonly idiopathic in origin, but it may also be congenital or secondary to neuromuscular disease, trauma, or infection. If it is secondary, then the primary concern has to be addressed. Idiopathic scoliosis, if the Cobb's angle is more than 45 degrees, then that will require a surgical repair. And the surgery aims to correct the curvature, improves the posture, and reduces the progression of respiratory dysfunction. So why I say about reducing the progression of respiratory dysfunction is if it is an idiopathic scoliosis, if it is detected at an earlier stage, then if you correct the scoliosis, then the parenchymal lung function can be preserved. That is the whole idea of doing an early surgery. And also cardiorespiratory dysfunction may exist as a result of progressive scoliosis if it is done at a later stage or may be related to the coexisting disease. And therefore, a preoperative assessment is a must. So intraoperative considerations, we should take care of the prone positioning, avoiding hypothermia, minimizing blood loss, and monitoring the spinal cord function. And in the postoperative period, we should have a good postoperative pain control and a respiratory physiotherapy for the better outcome of the patients. So this is what to be summarized. Thank you. Would you like to add something?
Nishant sir, we are open to questions.
Yes. That was a very, very useful session. Very, very nicely done, Dr. Anuprabha and Dr. Lydia. You've been very confident and very good. Just a little bit louder, Dr. Anuprabha, okay? Dr. Pratima, we have a few questions in the chat box.
Yes, sir.
Shall I stop the screen?
Yes, you may.
Yeah.
There's a question by Dr. Neeta Taneja. In cases of pulmonary hypertension, how do you manage fluids?
What is that? Can you come again?
In cases of pulmonary hypertension, how do you manage fluids?
Fluids.
Management.
Fluids. See, pulmonary hypertension is an irreversible damage which has already occurred. So fluid management will be guided. That is why I said about TEE. So if it can be guided by TEE, then pulmonary artery hypertension can be managed. So if at all, see, this scoliosis surgery is not a cardiac surgery. So we will have to maintain the pulmonary artery pressures from going up from the baseline. We'll have to maintain the physiology of the patient. So if the pulmonary artery pressures are somewhere between 35 to 45, then we will have to make sure that the patient does not have hypercarbia in the intraoperative period, hypoxia, hypothermia, which causes an increase in the pulmonary vascular resistance. And you should avoid use of nitrous oxide. So these are the common things which we take care of in a patient who is coming for pulmonary hypertension, any other pulmonary hypertension. So all those things have to be taken care of. So I think this answers the question.
Yes, ma'am.
Yeah.
There's another question by Dr. Malik. What to do if we have to give CPR in the surgery?
Yeah, this is a good question. Yeah, this is a prone positioning. So
we can use our automated CPR machine if you are having. In such cases, if available.
Otherwise, we will have to turn the patient.
There's a question by Dr. Mohan Pathak. Can tracheal trauma or perforation happen in this surgery?
What perforation?
Tracheal trauma.
Tracheal trauma or perforation of trachea.
Tracheal trauma. See,
So that is one problem with your wake up test, which you want to, which we wanted to tell. I mean, I have not come across any literature mentioning about it, but one problem of wake up test is there will be a startling response where your patient will basically bite the tube and there could be a puncture of the tube and there could be a dislodgement of the tube. I have never come across any tracheal trauma. I mean, literature, I have not gone through any literature which says about tracheal trauma.
Yes. See, this tracheal trauma can occur in two situations. One, if there is a cervical scoliosis, which causes airway difficulty and curvature of the trachea. So, if we do a blind intubation, then that can be a possibility. If the tube hitches, or if you try to thread a tube over a bougie, so that can occur. And see, more than tracheal trauma, it is extubation which might occur in a patient when wake up test is done.
Next, we have a question by Dr. N. Raghunandan. What are the preventive steps intraoperatively to avoid neuronal injury, or what newer monitoring which can be used by the anesthetist to direct the surgeons to take preventive measures as to prevent intraoperative complications?
So it's the same as IONM. It's the IONM which is coming up. And one more thing is we can use methylprednisolone if any injury is suspected. So methylprednisolone decreases the neuronal injury, but there is no literature which is suggesting methylprednisolone can be used as a used regularly or as a preemptive measure to prevent neurological injury. So that is what, if the neurological injury is suspected in the postoperative period, then in the immediate postoperative period, when the neurological injury is suspected, methylprednisolone can be used at the dose of 30 milligrams per kg body weight. But in the intraoperative period only, that is why we are going to do an intraoperative neuromuscular monitoring. And in case if SSCP and MEP or the evok potential is lost, we stop the surgery and we bring back the spinal cord to the original position, and we do it step by step. And
the destruction.
To minimize the destruction. So that is all. That is what can be done. Yeah.
There's a question by Dr. Parna Thakkar. Is dexmedetomidine used commonly for IV-PCA?
IV-PCA, no. IV-PCA, but its property can be used in scoliosis surgeries at a minimal dose. There is a possibility of sedation and bradycardia in this patient, in any patient in the IV-PCA.
There was another question by Dr. Motushi, CPR, which has already been discussed, how to give intraoperatively.
Somebody had answered. Now CPR is done in prone position also. I personally have not experienced or I have not done CPR in the prone position. That is why I didn't answer it. It is from the literatures. That's all. My personal experience is limited. Yeah.
There's a question by unknown person. What about DVT pump applied preoperatively?
DVT pump applied preoperatively. I think
we don't do that in the preoperative period, but we do it in the postoperative period. Actually, this is not a surgery which increases the risk of DVT in the postoperative period, because we try to ambulate the patient as early as possible.
There's another comment by Dr. Narendra Babu Channa. Methylprednisolone is used prophylactically by the ortho team. Is it commonly?
Our institutions do not use in the preoperative period. That is why we are not aware. But there are some people who are using methylprednisolone to decrease the inflammation and injury to the spinal cord. That's all.
Preoperatively.
Yeah.
There were a few questions, Pratima, early on by Dr. Raghunandan. What is the ideal neuromonitoring device which can be used?
That is what we, I think this question has been answered.
Answered.
Yeah.
Okay.
Any other senior people in the forum, if they are doing regularly, they can, yeah. They have experience, they can add on to the discussion.
This is one of the very few, rare surgeries which are
Which is regularly done, yeah.
So anybody who does frequently can please share your thoughts.
There is some question on any role of SGA. I wouldn't recommend the SGA for this patient.
Dr. Madhuri raised her hand. Let us speak.
Madhuri ma'am, yeah.
Yes, ma'am.
Pratibha,
Yeah,
if you permit, I
Yes,
know the
ma'am.
discussion is on scoliosis correction,
Yes, ma'am.
but sometimes the viva takes a turn, U-turn,
Yeah.
and the patient of scoliosis, the examiner will be fed up of asking the same thing, and he will ask you that this patient, shall I present the case to the PGs?
Yes, ma'am.
Anuprabha, suppose you have a 22-year-old, 39 weeks pregnant woman with cephalopelvic disproportion, and she is posted for an emergency cesarean section, and she gives a past history of surgery on her spine for correction of scoliosis at 9 years of age, and rods were placed from T4 to T12 vertebra for her. So how will you do the anesthetic management? Just think, because such kind of, yeah.
Coming for
Emergency. History of scoliosis surgery. Rods are placed from T4 to T12 when she was 9 years old. Now she is 22 years old. Full term primi gravida with CPD.
There will be difficulty in spinal anesthesia. If with ultrasound imaging we can proceed, but in emergency situation it would be riskier.
This ma'am gave it a CPD, so this is going to be an elective surgery.
Emergency situation. So we'll proceed with general anesthesia as the first choice of.
Why not spinal?
No, this is CPD. That's what ma'am gave. It is
Yes,
not
yes.
an emergency. It is an elective surgery.
Elective surgery.
It's an elective surgery. Yeah.
No. It is not elective. It's an
Oh,
emergency.
it's an emergency. Okay.
And ma'am has given you the level at which the rods were placed.
Yes. T4 to T12.
Then it may be safer to opt for spinal anesthesia, but we
Why?
can under ultrasound guidance if permits.
You have to see first check the lumbar vertebrae, right? Because you're giving a lumbar spinal.
Yeah.
So if the lumbar vertebrae are okay, then
Case are okay, then we can proceed under spinal anesthesia.
okay. But what are the problems of spinal anesthesia?
The thoracic curvature will not be there after the correction surgery.
Okay.
So setting level of the sensory blockade of spinal anesthesia will vary.
And the volume of CSF will be less.
So
Right.
Fibrosed segments also, no?
Yes. And if there has been restrictive lung disease, even after the correction, it may not recede, right? So the patient may have restrictive lung disease also. So you have to look into that also. Anything else? You will see the scar over there of the rods, right?
More additions.
So you can try giving a spinal.
in lumbar region.
Okay.
Anu and Lydia, you know, when I was I think you were a PG student, when I was a senior resident long back, almost 2 decades back, there was this case which Dr. Madhuri just mentioned, a case of severe kyphoscoliosis came for the emergency section. You know, that time I put the spinal, very difficult to locate. First of all, the location is very difficult. If the spine is severely scoliotic and kyphotic, you will not be finding the midline, how to go. Somehow got the space, the fluid came, injected the drug, 2.2 ml. That was good enough for a section, although she was slightly taller, but the upper part of the body made her height little shorter for that. Then when the surgery started, the legs were just like legs gone, motor power totally gone. When the surgery started, she was having a severe pain with the motor power totally gone. I thought that spinal level is, I think, little bit lesser or something like that. Then till I think mid of thigh, she was having sensation. Lower legs totally gone. And later on that time, I think 2 decades back, there was not much literature on that thing. I searched the net also, searched the books also. There came one finding that in these cases, over a span of time, even if the corrective surgery has not been done, there can be adhesions, fibrosis in the spinal canal, which can always obstruct the dynamic circulation of the CSF, which can make the effect just limited to the lower half of the body. You will not get a typical that level ascribed to the lumbar blockade, where you put into even L2, 3 or 3, 4. You may not get a level higher up if the movement is obstructed. So that case, I had to intubate. And after the intubation, I know it was a nightmare for a senior resident. And the impression goes bad if the patient doesn't come out. Somehow try to be with the patient for next 3 days. My this one was very much, pale till she came out. And that was something. These patients can present you with anything, anytime, but the lungs are very bad in these patients. Very bad. The choice is final, but with the emergency there, you can't avoid it. All the skin incision has been done and she was in utmost pain. You can't give that face mask, ketamine and all those things, something like that. That is very much, difficult to handle these type of patients. Definitely today's case was very difficult. You discussed, you answered almost many things. And definitely one question was what I was thinking about the awake test. I think it should be made unethical now in the law. You should not wake a patient in the midst of a surgery when you have got a good facilities for the ICU care, where there was somatosensory evoke potential, the motor evoke potential, and other new gadgets are coming. So why should we make a patient awake? And all the chapters written on the awareness of anesthesia, you may not be knowing what catastrophe it may have on the patient, the patient mind.
Post-traumatic stress disorder is too much to handle for the patients.
Not only stress, I think the experience, the reputation about the doctors.
Yes, sir.
So many things he or she can hear when the patient get awake, not just on getting awake, rather during the process of waking up. The patient, the subconscious mind keeps on hearing. I think that should be discarded now as a treatment modality or therapeutic modality during the surgery. That is, I think. Rest, I think anybody wants to give suggestion, they can unmute themselves.
Yes, sir. We have Naveen Malhotra, sir. We have Venkat Giri, sir.
Yeah. Invite both of them.
Sir, if you could share some experiences of scoliosis, Naveen, sir, or anybody else.
Where is Dr. Venkatagiri? I am not able to see him.
Venkatagiri is very much here.
Turn on your video.
Should I?
Turn on your video, sir. Turn on your video.
Good evening, sir.
Or even with hiding also, you can ask the question. No problem about
that. What happened? Yes.
Your hand giving. I can see your hand giving thumbs up, but your question.
Yes. You can see me, no?
Yeah,
we can see you. Hello, sir.
You are very good at always making a good background screen.
Pratibha madam, good evening.
Dr. Giri, your suggestion or your question, whatever.
Lakshmi madam, you are president of Pondicherry or what we
Not
as
now,
that,
sir.
or
Not
post
now, sir.
scoliosis patient after surgery. That is what is the nightmare. If you get well and good, otherwise if becomes a patchy or does not act well is the problem.
Yeah.
But,
Sir, we fear the
but-
pulmonary complications and we go about with spinal. But if it becomes patchy, that becomes a nightmare already.
Yes, that's nightmare. Then if the gynecologist is good and all, still some sedation and all, we may, but then you should not tell to the PGs. But in the practice, we sometimes see the level and all and manage. What I see is where is the scar and take X-ray and all. See if the scar is not there, where we give that and it becomes a easy spinal. Usually, this patient sit and give, not in the lateral decubitus position because position may be difficult. Make them sit. And we get that. If in lateral, because bending and all is really difficult, sitting is easier. And see that whether any space, there is no scar. When there is a scar, very difficult to put in. This is what, if anybody get the spinal, yes, do that. Otherwise, difficult. That's what.
Nowadays, we are using ultrasound now, sir. We can use ultrasound to.
Guided has made.
Okay.
Now
I have
we are
not
using
started.
it.
I have not started using ultrasound.
We have just now started it, sir. For spinal, we are using it as a guidance to identify the space, intrathecal space.
We are just using it as a guide. We have still not tried ultrasound assisted. We are not doing, sir. We just use it as a guide.
Measure the depth and we find the intrathecal, interspinous space we find out and we go about it, sir.
Okay.
They're starting to use it now, sir.
Okay.
Anybody else want to share the experiences or suggestions or any questions?
Can we please make a YouTube link and share it on the group to revise the lecture?
It will appear only when the class ends, not now. Or you can go to live streaming part also. You can see it now, but after the class end, it will be uploaded automatically there.
Okay. Where, sir?
Hello.
isaweb.in, you go to the ISA, this one, ISA NHQ at YouTube.
Oh, okay. Thank you.
For the first time. Otherwise, it is always available in our website. All the previous you can go through and see.
This class is also available.
Actually, the new website is being, created, a new website. So very soon, the new website will be having a very dynamic interaction of how to upload immediately there also.
Okay.
Hello.
Yeah, Dr. Mohan
Hello.
Patel, sir.
Sir, I had asked a question regarding a tracheal trauma.
Yes,
It
was
not related to today's topic, maybe. But, hello.
Yeah. Sir, be little bit louder now.
Hello. Dr. Pathak here.
Yes, sir, please.
Hello.
Sir, please
Can
ask
you hear
the
me?
question.
Hello, can you hear me?
Yes, Dr. Pathak.
We can hear you, sir. Just speak just ask the question.
Yeah, I had asked question regarding tracheal perforation or trauma after intubation. We had one case of thyroid surgery. Just after intubation, patient was sinking. Then they noticed crepitus in the area of neck. They could not revive the patient. They lost the patient. But after having one X-ray, she had a bilateral pneumothorax. Intubation was not very difficult. Tracheal trauma or perforation, how frequently or anybody has come across tracheal trauma, tracheal perforation? Either it can be either barotrauma or tracheal perforation. Barotrauma was not possible because it was a hand ventilation with the small boils. It was not ventilator in this case.
Not necessarily, no, sir. If there is a bleb or something, it can always happen. Any bleb rupture can cause pneumothorax. There are two possibilities. If there is a traumatic intubation, there is always a possibility of tracheal injury. Or if it is not a tracheal injury, then if there is an isolated bleb which ruptures, which does not withstand the pressure of hand ventilation, that also can cause a pneumothorax. We have had one case in the past in the scoliosis surgery, something like this. But this was not, I think your case was not scoliosis, it was thyroid, right?
It was a normal thyroid nodule patient.
Thyroid nodule,
Thyroid
yeah.
nodule for hemothyroidectomy or excision of nodule, and she had a bilateral pneumothorax. It was not possible with the impingement of bulla. She did not have. All the investigation was normal. X-ray chest was normal. 2D echo was normal. Middle aged PS patient. Just
If
after
it was an
routine
atraumatic,
intubation, she developed.
if it was an atraumatic intubation, then the possibility is very less. Or if it is a long-standing thyroid, which can cause tracheomalacia, can lead to it. If there is a subcutaneous emphysema associated with that, then we can think of it. Yeah, there might be a possibility. The most important thing is pneumothorax has to be identified. We will never know the cause of desaturation if we don't suspect pneumothorax. So that is why airway pressures are important. If you are using a ventilator, then airway pressures are important. If you are using a hand ventilation, then we will have to look for the bag compliance. A tight bag syndrome has to be noted. So that is one important point. Yeah. And desaturation. Yeah.
Pathak sir.
3 to 4 centimeter nodule. That's all.
Pathak sir, what happens actually in these type of surgeries? Experience of these things. At least 3 tracheostomies, where those were done and the emergencies by the senior residents of the ENT and surgery. We had the incidence of bilateral pneumothorax there, because whenever you're doing these tracheostomies, you are opening up the fascias laterally also sometimes. The fascia is sometimes so loose, or because of the bulle rupture also. I've seen it during thyroid surgery also. When you are operating on a thyroid surgery, you sometimes accidentally open up the fascia, which may not be anticipating or which may not be detecting at that particular time. But after some time, it's become more of a tension pneumothorax, which can cause the mortality, which can cause the sudden collapse of such patients. So it is a surgical, not just I think, we haven't not seen the cases of traumatic rupture so aggressively by the intubation with a stellate also. But the surgical part, we have seen many. There are many reported case reports where the thyroid surgery or even the tracheostomy or cricothyrotomy, you have come across the surgical emphysema or massive. So,
sir, I would like to add one point, sir. I would like to add one point. Normally, we notice a fall in saturation and we tend to vigorously ventilate. As you said earlier, this can lead to a tension pneumothorax also. So this is one possibility.
Yes, through the fascial layer, air can go inside and through the what Sukhvinder said, no, air can go through the fascial layers during this surgery. That was the one possibility somebody said. Yeah.
Yes.
Thank you, ma'am. Thank you, sir.
Anybody else want to add anything else? Dr. Madhuri wants to add something again, please. Unmute करके add होता madam. Unmute करो.
You have not asked gold medal question.
I don't have gold with me.
So shall I ask him?
You have gold, so you give it to me. I will ask.
I don't have gold. Anuprabha, you have answered all the questions so beautifully. So in the pre-operative assessment of a scoliotic patient, I think assessing the cardiopulmonary reserve is very important, right?
Yes.
Correct, no? So that you can do by so many tests and meds and all that you can find out. But there is one, exactly. So there is one exception to this. Can you tell me who it is who has got a scoliosis but yet has beaten all odds? Yes, a celebrity with scoliosis who beat all odds.
Can I get the gold medal?
No, not you. It is for the student. Yeah. I'll give you a hint. He's a sportsman. Because we're running short of time. See, madam knows the answer.
Giving the clue also.
Yes, give.
Given.
You give up? Both the girls give up?
I will tell the answer.
Usain Bolt.
No,
yes.
CR7. Cristiano Ronaldo.
Both, all of you are correct. Good. I'll send you all the gold afterwards, okay?
Yes, ma'am.
No, not rolled gold, real gold, not rolled gold.
Okay, thank you. So nice. Good discussion. Very good discussion.
Yes, and both the postgraduates were very confident and very, very well done. Anuprabha and Lydia, very nicely done. Sir, over to you, Bajwa sir.
मेरे साथ ओवर क्या करना, सारा कुछ ओवर कर दिया, बच्चों ने बहुत अच्छा किया है. Especially thankful, very thankful to the teachers. You know, they were up to the task, answering everything, and nothing was left behind, I think. Rather, they were searching for the question. That is more important. The moderator searching for the question, the chat box, and in everywhere. That was wonderful. This is what the essence of PG teaching is. Whatever the questions I think are being asked today, were asked today, not these our residents, but all the residents who are watching this program, who will be watching on a YouTube also, they will get very confident if they get such cases in their final examination. And that is the sense of these teaching. So by the time, and I think we complete another 2-3 years of this PG online classes, there will be no case left which cannot be discussed. I think that is how to proceed forward. And as I said you earlier also, next time we will be having some seminars, webinars, or presented by the PGs, and taken care by the moderator, so that theoretical classes can also be done, because the long questions in theory also come, so we can take up those questions also. I think that's the way to go for the PG classes. And today I'm really indebted to both the examiners as well as their students, and to my program coordinators, Dr. Madhuri, Dr. Nishant, and Pratima, who's spending the first day on the national platform. I think she did good enough with the confidence. And to all the audiences, our Venkatagiri sir was there, Dr. Naveen was there, and other people were also there, senior people. And thank you, everyone did a wonderful job today. It was a good PG class, good discussions, and good outcome.
So you want to give some certificates?
Certificates I've got with me. Let me see. I always forget the certificates actually.
You want to share?
No, they are there actually. Let me.
Sir, I would like to thank you all for this opportunity, and
It's a very good
experience for us also, sir. Thank you so much. Thank you.
Thank you,
And
Bajwa,
your
sir.
words has really meant to us as PG teachers. Thank you so much, sir.
This is a real platform, and I think all our PG teachers, they have done a wonderful job.
Yes.
Now, previously also and presently also.
Yes. Thank you, sir. Thank you so much.
Just wait for half minute. This one. I may not be able to show you in this one full online screen, but I will try. Visible?
Yes, sir.
Dr. Pratibhas.
Thank you, sir.
Is it fine? The spellings are fine?
Yes, sir.
Okay. Then next, Dr. Nagalakshmi.
Yes, sir.
Yeah, okay.
SPMCH and RC Research Center, sir.
Ma'am, we will do this
Yes,
one rectification,
yes,
and send it to you after rectification.
Yes.
Then Dr. Anuprabha.
Correct, sir.
Congratulations, Dr. Anu.
Thank you, sir.
Congratulations, Dr. Lydia. Dr. Pratima, you are as a coordinator in the ISA online PG class. Dr. Nishant, this time we are giving to our senior coordinators also.
Thank you, sir.
So this was the felicitation ceremony done. Dr. Venkatagiri.
Dr. Bajwa?
Yeah.
We are sending this physical copy or e-copy to them?
E-copy by email. Email.
Email. Okay.
By email, sir, by email to all the participants. The previous participants will also get. They are being specially created by our digital creator. So we will be sending them by email also, sir.
Somebody asked me today, previous participant whom to
Sir, actually, what happened? The previous participation, all the classes will be taken, their spelling will be checked, and we will be posting them by e-certificate. Yes.
Okay.
So fine. So let us get apart from today. Not apart, part us today. So in the next class, I will be conveying within 24 hours the next class also. I have not decided about it. So next class we will, I think tomorrow I will be conveying about that. Till then, next class we will say good night and long live ISA.
Long live ISA.
Good night. Good night, everyone.
Thank you.